Evening, everybody. A warm welcome to everyone on behalf of the Anaesthesia Association of Aurangabad, AAA, and the Society of Anaesthesiologists of Maharashtra, that is SAMS. The Anaesthesia Association of Aurangabad, that is AAA, is a vibrant community of anesthesian professionals dedicated to advancing education and research and patient care in Chhatrapati Sambhajinagar. The Anaesthesia Association of Aurangabad regularly organizes academic and non-academic activities, fostering professional growth and close association between its members. I'm thankful to the SAMS office bearer, Dr. Avinash Bhosle, sir, President SAMS, Dr. Sheetal Dalal, madam, Honorary Secretary SAMS, and Shilpa Tivaskar, madam, Editor SAMS Newsletter, for providing us Gineca platform for our webinar. Now, I will request Dr. Sangeeta Kulkarni, madam, to enlighten us about this, few words about this webinar. Over to you, madam.
Madam, please unmute yourself.
ठीक है Am I audible?
मॅडम तुमचा आवाज थोडा इको होतोय. तुम्ही 2 डिव्हाइस वरून लॉग इन केलाय का?
आवाज थोडा इको होतोय.
नाही मी आता एक मिनिट. नाही मी आता एक मिनिट.
आता व्यवस्थित आहे मॅडम.
आता येतोय?
येस येस.
ठीक आहे. Good evening and a very warm welcome to you all. Today we are deeply honored by the presence of our esteemed SAMS members, office bearers, and we are very thankful to all the SAMS office bearers for readily providing us this platform, and so that with the help of which we are able to listen all these webinars easily. And why we have chosen this topic is that nowadays we are coming across such type of patient, that is obese patients, for variety of operations, and anesthesia management in patients with such obesity requires multidisciplinary approach, which featuring and focusing on airway safety and respiratory optimization and tailoring of drug doses. So we will along with this surgery for OSA and bariatric surgery, we will also know the management of obese patient posted for other surgical procedures. So we are going to listen from the experts today, Dr. Mangal and Dr. Rashmi madam, the intricacies of management of obese patients for OSA and bariatric surgery. Over to you, Sachin.
Yes, thank you, madam. Now, as madam said, we are glad here to explore the important topic of obesity and anesthesia with our two experts, Dr. Mangal Murthy Chaudhary, our own treasurer AAA, and Dr. Rashmi Valimbe Deshmukh madam from Pune. Let's make the most of this webinar. According to the World Health Organization, the prevalence of obesity has significantly increased since 1975. Today, approximately 13% of the world population were labeled as the obese. In addition, over the past few decades, the prevalence of obesity has been steadily increasing. The Center of Disease Control and Prevention declares that about 35.7% of adults in the United States are now obese. So, the obesity is associated with comorbidities such as hypertension, type 2 diabetes, and coronary artery disease. Furthermore, the patients who are overweight or obese may also experience dyslipidemia, obstructive sleep apnea, liver and gallbladder diseases, osteoarthritis, cancers, and reproductive and psychological disorders. So due to this, many concomitant diseases and complications that accompany obesity, the management of obese patients, especially those undertaking surgical procedures, is now becoming increasingly challenging. The presence of this condition at some point may require surgical intervention, and therefore anesthesiologists are frequently faced with challenges of effectively managing obese patients along with their pre-existing comorbidities. Now, to lead our today's webinar, we are pleased to have Dr. Supriya Kulkarni, Madam, our own ex-honorary secretary, taking the chair as a chairperson. Now, I will introduce briefly about the Madam. So presently, Madam is very senior consultant anesthesiologist and pain physician. Presently, she is affiliated to Dr. Hedgewar Rugnalaya and R.K. Damani Medical College, Chhatrapati Sambhaji Nagar. She has 26 years of vast experience in this field with special interest in pain management, regional anesthesia, pediatric anesthesia, and anesthesia for critically ill patients. Presently, she is working as Vice President of Society of Study of Pain or Pain Aurangabad, and she is immediate past Honorary Secretary AAA. She has presented many papers and posters in state, national, and international conferences. She is IRCF and CRCT coordinator at Dr. Hedgewar Hospital. She is the recipient of President Appreciation Award by SAMS in 2025 and also a National President Appreciation Award in 2025. Thank you for gracing the occasion, Madam, and over to you. Thank you. Supriya, Madam.
Yes. Good evening, all. And thank you, Dr. Sachin, for wonderful introduction. First of all, I congratulate Dr. Sangeeta Kulkarni, Madam, Dr. Sachin, and all AAA office bearer for organizing a CME on such an important topic. I also thank all AAA office bearer for inviting me as a chairperson for today's webinar. As Dr. Sachin mentioned, that obesity is increasing globally nowadays. And I'm sure you all must have come across at least one morbid obese patient in a week for different kinds of surgeries. So obesity carries along with high risk like a diabetes, hypertension, airway diseases, liver diseases, and all other comorbidities which makes anesthesia challenging. So change in lifestyle and food habits contributes to this obesity. And this obesity, as this is increasing globally, the surgery for obesity, like corrective surgery for sleep apnea and bariatric surgery gaining the population nowadays. So today we have with us two experts to throw light on these topics. Surgeries for obesity, bariatric surgery, and sleep apnea surgery. So our first topic is surgeries for sleep apnea, OSA. And to present this topic, we have with us Dr. Mangalmurthy Chaudhary. It takes me immense pleasure to introduce him as a young dynamic, our AAA anesthesiologist, who is holding a post of treasurer presently. He was a freelancer anesthesiologist from 2009 up to 2019 at Chhatrapati Sambhaji Nagar. And after 2019, along with his colleague, he formed Vigilant Anesthesia Private Group, and he is a director of the same. He had managed very high-risk cases efficiently, and his areas of interest are high-risk cases, labor analgesia, protocol-based practice. In addition to that, he is provider and instructor of BLS, ACLS. He has also completed a pediatric advanced life support course, PALS, and advanced trauma life support course, ATLS, and ICU course. Also, he is actively involved in various social activities. So I welcome you, Dr. Mangalmurthy, and I request you to kindly start your presentation.
Thank you, our own AAA association, along with all SAMS office bearer and all the anesthesiologists who are there to attend this webinar. So I will start. My topic is anesthesia for obstructive sleep apnea surgery. This is very vast and new topic, And in this 20 minutes, I will give you overview and illustrate basic principle about OSA and its anesthesia management. I will mainly focus on pre-op assessment, pre-op planning, and Valimbe madam will go through details of induction to extubation and post-op management. And I am very clear that for more clarity, you all people will study this topic in depth after this session. Objectives of today's sessions are understanding obstructive sleep apnea, anatomy, physiology, and treatment of OSA, investigation and sleep study, anesthesia for adult OSA, and drug-induced sleep endoscopy, that is DISE, DISE, pediatric OSA overview. What is OSA? In OSA, there are our soft tissues like tongue, palate, the smooth muscle tone is reduced. So there is airway obstruction intermittently in night time while patient is asleep. In this, there are two important concepts we need to know: apnea and hypoapnea. Apnea means when breathing completely stops or drop it to less than 10% of normal airflow for at least 10 seconds. Hypoapnea means partial blockage that causes shallow breathing, defined as reduction in airflow of 30% or more for at least 10 seconds. Hypoapnea, that means if normal patient taking tidal volume of 500 ml, then if 150 ml or less than that, he is taking tidal volume, that means he is taking hypoapnea or shallow breaths. So in this figure, we can see the airway, oral and nasal airway is blocked in lower figure. Sign symptoms are obstructive sleep apnea, snoring, choking or gasping for air in sleep, feeling tired during daytime, having poor memory or being forgetful, experience multiple nighttime bathroom trips, having headache in morning headache. We diagnose ASA with stop bang score. Stop bangs, STOPBANG. This stands for short form S for snoring loudly. That much loud बाजू के रूम का बंदा भी उसको सुन सकता है, उतना लाउड स्नोरिंग होता है. T for tiredness in the day. O for observed apnea, means someone will observe that you are getting apnea. P for high blood pressure. B for BMI more than 35. A for age more than 50. N for neck circumference more than 40 centimeter. G for male gender. Low risk are 0 to 2, intermediate risk 3 to 4, high risk are 5 to 8. Means if AHI is more than 4, patient are high risk, and in certain criteria, if BMI is more than 35 or neck circumference more than 40 centimeter or male patient, we can consider them high risk even if their AHI are 3 to 4. And important to know is if AHI is 0 to 2, means he is only having snoring. That means all snorer are not OSA patients. They may be in future OSA patient, but not every snorer is OSA patient. This we need to understand because many of people snores and he or she may feel that they are snorer or OSA patients. AHA, AHI, apnea hypoapnea index. So 0 to 5 AHI is normal in adults. 5 to 15 is mild sleep apnea. 15 to 30 is moderate, and above 30 AHI is severe sleep apnea. This is in adult scoring. In children, there should not be any snore. Within 1 hour, 0 AHI is normal. 1 to 5 AHI is mild. 5 to 10 is moderate, and more than 10 snores is severe. This AHI, that is apnea hypoapnea index, is calculated in sleep study, overnight sleep study we do, and within 1 hour, how much apnea or hypoapnea, addition of apnea plus hypoapnea patient is getting, that is called apnea hypoapnea index. And we need to understand this scoring. Now, why we are discussing this topic is because prevalence of obstructive sleep apnea, as per studies, it is up from 9 to 38% in global adult population. It is more in men. Risk factors, risk increases with age and obesity. That means we are already giving anesthesia to these patients Let's clear the confusion that OSA means not every patient is obese. As per studies, 20 to 40% of OSA patients are non-obese. And as we are giving anesthesia to these patients, so we need to study this topic in depth. I will focus more on pre-op part. So medical treatment gold standard is CPAP, that is continuous positive airway pressure, which opens the airway during sleep. And other types are ATO CPAP and BiPAP when there is need of high pressure. For anatomical issues of the patient, they will need mandibular advancement device and tongue retaining device if CPAP fails. This is nasal CPAP. This is well tolerated previously. There are oral CPAP. This is CPAP machine. Other lifestyle modification are weight loss, limiting alcohol, smoking cessation, and positional therapy. Avoid sleeping in supine position. Surgical consultation only needed when patient is intolerant to CPAP. Means every patient will not need surgery. If he is intolerant to CPAP, then only surgery. Persistent inadequate CPAP adherence owing to pressure related issues and obvious upper airway anatomic abnormality, which is not amenable, which is not treated with CPAP. Commonly performed obstructive sleep apnea surgeries are of nose, throat, tongue, maxilla, and mandible. In nose, we perform septoplasty, turbinoplasty, throat, UPPP, that is uvulo-palato-pharyngoplasty, tonsillectomy, adenectomy. In tongue, base of tongue surgery, genioglossus advancement surgery. Then there is maxilla and mandibular surgery. This is performed along with maxillofacial surgeon, ENT surgeon, and maxillofacial surgeon. And hypoglossal nerve stimulation by device implantation still to be done in India. It is not authorized still date. Why we are studying this topic? As study shows that OSC is an independent risk factor for perioperative morbidity. OSC patient have twice the rate of hospitalization in last 3 years before they are diagnosed as OSA patient. Overall, 4.7% of OSA patient were transferred directly to ICU post-operatively. 30 days mortality is 0.64%, 1 year mortality is 5.78%, 2 year mortality is 7.77%. So, in short, OSA increases perioperative mortality and morbidity. So, we need to study this topic in depth. Causes of OSA are anatomic issues like soft tissue issues, tonsillar hypertrophy, palate abnormality, enlarged uvula, enlarged tongue. Then there is retroposition of mandible, that is retrognathia. In that case, vocal cords are anterior while intubation. Chubby cheeks are there. Then heavy jaw, that makes difficult ventilation. Short neck, increased neck circumference in obese patient. Non-obese OSA patients may have anatomic issue, that is congenital anomalies like short mandible, maxilla pathology, high arch palate, and they may have soft tissue issues. That means 80% patients are 80% OSA patients are obese, and 20 to 40% patients of OSA are not obese. They get obstructive sleep apnea mainly because of bony issues and sometimes because of soft tissue issues. Obstructive sleep apnea means some airway issue. So we are going to get difficult intubation and difficult ventilation. So we need to study this. So this is orthognathia, retrognathia we can see. When we examine patient in lateral position, examine his face, then only we can identify whether he is having retrognathia or prognathism. Otherwise, we will miss this important part, and we may feel by looking at the smart face that this is a normal intubation. But when we look face in lateral angle, then only we will see mandible is retrognathia. Now, altered physiology, as they are getting airway closure, so they are getting intermittent hypoxia and hypercapnia overnight, resulting in oxidative stress and systemic inflammation. They are having, the patient are having low oxygen reserve, and they are used to CO2 retention, that is hypercapnia. And because of all this, they are getting hypertension. And they are also, sleep apnea is also associated with a lot of other comorbidities like diabetes, stroke, different comorbidities are mentioned here, and mostly patient land up in vicious cycle. Once they get OSA, they get obesity and all other comorbidity, and vicious cycle will continue. Now, ASA 2012 guidelines for evaluation, that is evaluation of all medical reports, then sleep study evaluation, we will discuss in detail. Then patient's history taking. In history taking, we take history from the patient as well as from relatives. Take history of stop bank, do stop bank scoring also, and also ask patient how much pillows he used to take while in night. Do proper evaluation routine, all systemic evaluation along with airway evaluation, and do all airway evaluation like MPC grading, mouth opening, then thyromental distance, neck circumference is very mandatory, as obstructive sleep apnea causes narrowing of airway, and patient takes breathing inspire through narrowed airway. So over a period, patient will get retrognathia and large tongue because of excessive use of inspiratory muscle. So examining all these factors are important. We will do routine lab test, and as per comorbidity, we will do other ECG, equine, HbA1c, all other fitness tests. Society of Anesthesia means CPAP is very important treatment. We need to ask history of CPAP to each and every patient. And as in routine practice, I observed if we don't ask history of whether patient is using preoperative CPAP, many of patient will not tell that they are using preoperative CPAP. So if we ask them leading question whether you are using CPAP, then he will say yes. Then we need to understand his CPAP machine and all the settings preoperatively, because we need to continue same CPAP machine post extubation for next maybe 1 to 2 days. And continue pre-op CPAP is very necessary as per studies. Then pre-op weight loss, CPAP therapy, abstinence of alcohol, stop smoking, bronchodilation, incentive spirometry, motivating patient. This is all important in pre-op optimization. Then treat all comorbidities. Which patients are unfit? When you call patient is unfit, when patient is having chest issues like URTI, LRTI, then uncontrolled or not optimized asthma, COPD, patient is active smoker, then severe OSA patient which are not well prepared with perioperative CPAP therapy. Usually we wait for 15 days. Then inadequate infrastructure to manage such as cases, and team not well prepared. This is very important things. Sleep study, it is a big 4 or 5 pages report which confuses us. So what is important is go to last page, summary page, where you can see means how much apnea he is getting, patient is getting, he or she, hypoapnea index, and this index is for 1 hour. So in this trial report, we can see apnea index of 123, hypoapnea is 2.7, addition of both is AHI, that is 125 and 125.8. So in this patient, in 60 minutes, he is getting 125 episodes of apnea and hypoapnea. That means every minute he is getting apnea or hypoapnea twice. And we need to also to look for minimum SpO2, which is 58. So these patients are used for hypoxemia. And another indexes are oxygen desaturation index, that is OD index, and arousal index. Oxygen desaturation index here is 77, means he is getting desaturated in 60 minutes for 77 times, means every minute he is getting desaturated. His body is used for this. And arousal index in this patient is 38.8. That means he is getting aroused for 38 times in 1 hour, that is 60 minutes. Every alternate minute he is getting awake because of hypoxia. And ENT surgeon usually do drug-induced sleep study for planning the sleep surgery. So if AHI is more than 60, the patient is unfit for DISE. then we need to give CPAP therapy, optimize the patient, and then only do drug-induced sleep study. In drug-induced sleep study, we use midazolam, dexmed, propofol. Here we do this drug-induced sleep study to know the level of obstruction and plan the surgery, which surgery. And most important is we give all this anesthesia agent without oxygen. Very important, without oxygen. As these patients are used for hypoxemia, so our goal of drug-induced sleep evaluation is patient should sleep and snore. He should achieve lowest saturation, which is seen in sleep study. And always keep in mind not to give over sedation, because over sedation will cause spurious result and decision of surgery is depend on this. So patience and perseverance is key. We do this drug-induced sleep study to check level of collapse like this. Recent studies shows that dexmed is better as it induces a state of that resemble normal sleep. Dexmed has lower rate of respiratory depression. It is hemodynamically more stable. Onset time is 5 minutes. Monitoring very essential. Pulse ox, ETCO2, as we can predict apneic episode from ETCO2. BIS monitor, that is bispectral index. We keep BIS between above 70 usually. Proper size nasal airway. Then keep all emergency airway gadgets. If necessary, we may need to intubate the patient. Actually, there is no need if you go slowly and patiently. This is regarding BIS. So our goal is patient should respond to verbal command and mild stimuli, and patient should be cool, calm, sleeping. And his spontaneous breathing and cardiovascular function should be maintained. Our approach is we use usually midazolam and dexmed. Usually 10 to 20 minutes are needed. And in 10 to 20% patient, we use propofol in small alicate 1 to 2 ml. Do not use propofol initially, because giving propofol will patient will end up in respiratory complication. Our protocol is don't perform drug-induced sleep evaluation for all patients whose AHI is above 60. And if patient is having AHI more than 30, they need to be optimized for at least 15 days. Because of CPAP treatment, patient will develop muscle tone and body will acclimatize for normal physiology. As initially the surgeons perform OSA surgery without optimization, and they landed in increased mortality and morbidity within first 30 days. So patient optimization is very essential. OSA surgery, usually it is a multi-stage surgery, means we operate nose, palate, tonsil, multiple level we need to operate. So usually we do it in single stage or multiple stage. In our setup, we prefer multiple stages surgery, one step one by one. So this is having good outcome with multiple stages surgery, and as our setup is having possibility of ICU setup, so multiple stages surgery is always better. Basic preparation for difficult airway cart. Valimbe madam will go in depth with this all thing. Important is assign an individual for assistance, and pre-anesthesia, pre-oxygenation by mask, administration of supplemental oxygen while intubating the patient is essential. Our major goal is preserve oxygenation and prevent airway collapse. Key steps are in obese patients are RAM position throughout pre-oxygenation, CPAP or PEEP support, and slow titrated induction. Role of pre-oxygenation and apnea period in difficult intubation. Before induction, if we pre-oxygenate patient with 100% oxygen for 3 to 5 minutes, or we will give 8 vital capacity breathe, then and keep patient in apnea and study the safe apnea period. If we don't pre-oxygenate the patient, the safe apnea period is less than 1 minute. If we do proper pre-oxygenation, we will get 6 to 8 minutes. These are as per studies in normal adult. In children, this time is 5 minutes. In obese patient, safe apnea time means patient will not desaturate, patient will maintain SpO2 above 90%. In obese patient, patient will maintain its saturation till 2.7 minutes in supine position, and if we do give head up position, again 50 seconds will be more added. So we need to understand this concept because in difficult intubation, if we will get around 2-3 minutes time, then it is we are comfortable to intubate this patient. So this is very important concept. How to tackle difficult intubation: keep your plan A and plan B ready, keep your head cool and calm, keep assistance ready, and most important is, if needed, be ready to bring patient out of anesthesia, keeping ego aside. This is very important. Patient OT table in proper position and ramp position, pre-oxygenation, keep all gadgets ready, give calculated dose of induction drugs. Two-hand ventilation is very necessary. Jaw thrust, put oral airway when patient is under anesthesia, give relaxant once you can ventilate well, and follow standard difficult airway guideline. That is, your first attempt should be best attempt, plan for that, and take only 2 attempts and then stop, call for help, and then proceed. Keep ventilating patient in between. Be calm, and we can use apneic high flow nasal oxygenation. High flow means around 20 to 80 liter of oxygen. So in mask ventilation, we will keep mouth open so that and jaw thrust so that tongue will not fall. And this is standard sniffing position where neck should be flexed. Look in this figure at C6, C7 level. Many of initial days we extend the neck. So this should not happen. Neck should be neutral or flexed to 35 degrees, and head at atlantoaxial level, that is C1, C2, that should be extended. Not neck should be extended. Many of time we do this in hurry. So this is tragus to nipple line, or tragus to nipple line in male, or tragus to sternum in female. This line should be parallel to the floor. In this second, we put pillows. So this is in horizontally. So we can intubate and we will visualize cords, and in this head is hanging. So this line is going upward. So this we will end up in difficult intubation, that as cord are situated in anterior part of the neck. So we need to give pillow. This is again not proper position. So when we give pillow plus cloth, this line will be parallel. So this is an easy intubation. This optimum intubating position is very necessary. In obese patient, always keep in mind shoulder broadness or trunk width is essential, as this trunk width is varies with each and every patient. And as I said, trachea is located in anterior 1/3 of neck. So give pillow as per that scenario. As we give shoulder support in children's, this is to bring this line. So I will take 2 to 3 minutes more. Is it okay, ma'am? Thank you. Anesthesia maintenance, good depth with all our routine drugs. Give preemptive analgesia before incision, like NSAIDs, paracetamol, local anesthesia. Sound intraop management with IV steroid, because it reduces airway edema, reduces post-op nausea, vomiting, post-op pain. Give it before incision. Give tranexamic acid to reduce the bleeding. And most important is maintain heart rate around 60, BP around 160 or 90 to 60. Maintain EtCO2 30 to 35 and normothermia. As maintaining all these parameters will reduce arterial and venous bleeding, which indirectly improves surgical field and endoscopic vision. We control our parameter, and by giving proper doses of anesthetic drug, And sometimes IV labetalol, metoprolol, or NTG is needed to control the parameter. So balance anesthesia is crux to good intra-op condition and smooth recovery. Reversal agent Sugammadex is better than neostigmine as per new studies. As Sugammadex gives complete recovery, muscle recovery. Then extubation always in head up position, put oral or nasal airway before giving reversal and patient before becoming conscious. Then important aspect is in post-op management, we need to understand that brain chemoreceptor are located in medulla oblongata, plays a critical role for maintaining hemostasis by signaling the brain to increase breathing, hyperventilation to expel excess CO2. When there is increase in EtCO2, chemoreceptor activated, which increases respiratory rate. But under anesthesia, this chemoreceptor is not going to get activated. So these patients are under anesthesia, their respiration because of fall in SpO2 and rise in EtCO2, their chemoreceptor are not sensitive and they are getting apneic episode post extubation. So reintubations are possible here, needed here. So that's why we need to extubate them at proper timing. Post-op monitoring is essential. Propped up position, oxygen and nasal or oral airway till patient tolerate, and CPAP for all patients if they are using it preoperatively. Then adult OSA basic idea is be ready for difficult intubation and follow the ASA difficult airway guideline. Maintained proper plane of anesthesia as per plan, multimodal analgesia, extubate in head up position, plus airway if needed, and post-op close monitoring for next 3 to 4 hours. Pediatric OSA mainly adenotonsil because of adenoid and tonsillar hypertrophy. Patients are getting obstructive sleep apnea in pediatrics. So main surgery is adenoid and tonsil. So proper pre-op assessment is needed and post-op monitoring for at least 3 hours. In severe cases, we need ICU support. Anesthesia induction, we use usually armor tube to avoid tube compression and kinking, and keep watch on airway pressure. And intermittent every 10 minutes, we need to release the Boyce-Davis mouth gag. Extubation, we can do it deep or wide awake, as newer studies suggest that even deep extubation is safe, as when patient is fully awake, there is chances of persistent coughing and bleeding from the surgical side, and there we may end up in complication. So IV steroid is also necessary. So what is important is the eye can't see what the mind doesn't know. If we don't know obstructive sleep apnea, so we can't predict the intra-op, post-op complication and issues. So thank you for listening this. Take-home message is OSA is not difficult. It is just a different, and managing OSA patient needs anticipation to avoid perioperative complication and not fear. So these are my references. Thank you.
Yes, thank you, Mangal Murthy. It's a very informative and crisp lecture. So many ideas must be cleared of everyone. So can we take question answer now or in the end, Dr. Sachi?
Madam, we will take in the end. We'll continue with our second talk.
Yes.
Okay.
Meanwhile, if anybody have any questions, they can post in the chat box.
Okay, then we'll take question answer at the end. We will begin with our next topic, that is bariatric anesthesia for bariatric surgery. And for this today we have with us Dr. Rashmi Walimbe. She is a senior consultant anesthesiologist at Apulki Medical Center, Pune. She is dealing with many bariatric surgeries, and her major achievements and awards are: she presented a case report on myasthenia gravis patient for bariatric surgery in ASOCon 2018 at Delhi. Also presented a case report on pulmonary hypertension patient for a bariatric surgery in ASOCON 2018 at Delhi. She presented a poster on pulmonary hypertension case report at IFSO 2018 at Dubai conference. She won the first prize for presentation on erectrospiny block as a component of multimodal analgesia for bariatric surgery in ASOCON 2019 at Ahmedabad. Paper presentation on pulmonary hypertension in obese at MISACON 2019 Solapur. She also published a case report on DOF patient with kyphoscoliosis with severe restrictive airway diseases for bilateral tibia nailing under the ultrasound guided spinal anesthesia. So she has a vast experience in managing the obese patients. So we are eager to listen from her. Dr. Rashmi, you're welcome and kindly start.
Thank you, madam, for the kind introduction. I bring with me warm regards from SAP, that is Society of Anaesthesiologists Pune and Apulki Medical Center Pune. I would like to share my presentation here. I have no conflict of interest. WHO has defined obesity as a condition in which the percentage body fat is increased to an extent in which health and well-being of the person are impaired. Due to alarming increase in the prevalence, WHO has declared it as a pandemic. According to ICMR studies in some parts of India, the incidence of obesity is as high as 40%. So, anesthesia for bariatric surgeries or anesthesia for patients with obesity is becoming more and more common in our setup. So this is the WHO classification of obesity. But if you see region-wise classification, so the Asia Pacific region has declared obesity as BMI more than 25 kg per meter square, whereas WHO defines obesity as BMI more than 30. So we are way more predisposable to obesity. Other parameters to define obesity are like waist circumference, waist to hip ratio, waist to height ratio, and skin fold thickness. So before starting a obese patient, a case of the bariatric surgery, we should ask ourselves a few questions. The first is your patient ready? Is your hospital ready? Is your OT ready? Are your OT staff and assistants ready? And lastly, are you ready to take up the bariatric patient? So to quantify patient readiness, I like to do an advanced PSC for my patient. I like to see my patients at least 1 or 2 weeks prior to surgery. Most of the times the patient comes to us fully investigated. But still, if not done, I would always like to do a 2D echo and a pre-operative ABG if the patient's BMI is more than 40 or 45 kg per meter square. Most of these patients have metabolic syndrome. Investigations are already done, but if not done, we would try to go ahead with these investigations. Most of these patients have OSA, hypertension, diabetes, heart disease, dyslipidemia, endocrine abnormalities, PCOS in females, erectile dysfunction in males, and they are a few of our patients, they are sleepy even while we are doing PSC. So one of my patients was dozing off while talking to me. So if such a patient comes to you, then you know that this patient definitely requires optimization, and I cannot go ahead with the surgery for this patient because he is at a high risk of developing type 2 respiratory failure in the post-op period. So these patients require respiratory rehabilitation and optimization, nutritional support, and liver preparation. I have included a liver photo here. This patient on USG report, his USG report showed grade 1 fatty liver. And when we put in a laparoscope, that was the picture of the liver. So the USG is always you take 2D echo and USG with a pinch of salt for these patients, because the echo window is very poor. So the USG report may not show actual picture. Also, these patients most of the times are depressed because of body shaming throughout their lives. So they require a great lot of motivation and psychological support. But this is how we diagnose metabolic syndrome. So it depends on the five. There are 5 criteria. Out of that, at least 3 should be present to define the patient as having metabolic syndrome. Now, how do we assess hospital readiness? So, obese patients are not to be operated in small nursing homes. They require better centers. Hospital should have wider and higher weight-bearing chairs so that the patient can sit on them. The chair doesn't break after the patient sits. The bariatric beds should be available. They are high capacity and high weight-bearing capacity and wider. The doors of the hospital should be, and the room door should be wider. The toilet seats should be floor mounted and having a higher weight bearing capacity. Otherwise, if the patient falls from the toilet seat, it is a catastrophe. Many patients, we had one patient who used to doze off on the toilet seat at night at her home, because she used to wake up, she couldn't lie down on bed, and she used to wake up very frequently while sleeping. Then the staff should be very cordial and there should be no gossip. OT readiness has to be assessed. You should have a bariatric OT table which are wider and have a higher weight bearing capacity. Most of our tables, whatever the weight bearing capacity is written, that is only in a straight position. That is 0 level. If so, you have to particularly see whether after head up position the same weight bearing capacity is there or it is less. Bariatric tables are available with in India with the weight bearing capacity of around 450 kgs. The anesthesia workstation should have a pressure controlled mode. Sometimes it is very difficult to ventilate the patient on volume controlled after the pneumoperitoneum is established. You need to have longer laparoscopic instruments. Sometimes the abdominal wall thickness in this patient itself is 6 to 8 inches. So your instruments have to be longer. There have to be harnesses and belts to tie the patient to the OT table. These patients have changed their center of gravity, so they just may slip off the OT table and fall. Also, you need to have patient trolleys which have a higher weight bearing capacity to transport the patient. OT staff has to be trained for bariatric surgery, and your assistants have to be trained for assisting you in airway management and regional blocks. The staff has to be cordial and efficient in dealing with these patients, and they should have good knowledge about minimal access surgeries, because most of the surgeries are minimal access because it is very difficult to do a laparotomy in a bariatric patient, and the post-op morbidity is also very high. Lastly, you have to ascertain that you yourself are trained enough to handle a obese patient, because you have to have a proper knowledge of their pulmonary and cardiovascular dynamics. So there are what are the types of bariatric surgery? They are mainly divided into 2 types: restrictive and malabsorptive. So first, the simplest one is gastric balloon. The balloon is usually kept in the stomach for 6 months. The patient usually reduces 15 to 20 kgs of weight in this 6 months. But the problem is when the balloon is removed, the patient tends to regain all the lost weight. Next, commoner done previously, but nowadays not done much, is gastric banding. Then the duodenal switch operation. And lastly, these are the 3 most commonly performed bariatric surgeries. That is the sleeve gastrectomy, the Roux-en-Y gastric bypass, and a mini gastric bypass. So dealing with some weights. So what are the different weights you come across? So first is the total body weight. That is the actual weight of the patient which you see on the weighing scale. Then next is the ideal body weight. So that is the ratio of the lean mass to fat mass of the patient, how much he should weigh. So approximately it is calculated by using Broca's index. That is, in males it is height in centimeters minus 100, and in females it is height in centimeters minus 105. Next is the lean body weight. That is patient's weight minus the fat weight. And adjusted body weight. Adjusted body weight is the lean body weight in addition to 40% of the excessive body weight of the patient. So these are few formula. They are quite complicated, so you can roughly use Broca's index or adjusted body weight. So this is a relationship between the adipose tissue weight and the lean body weight in a normal patient as against an obese patient. So from the graph, you can see that up to a certain body weight, the lean body weight increases with the total body weight. Whereas after a certain amount of weight, only the fat mass increases, whereas the lean body weight remains stable. So roughly in any average Indian female, the lean body weight is never above 50 or 55. And in an average Indian male, the lean body weight is never above 70 kgs. So what are the indications for bariatric surgery? Firstly, if the BMI is more than 37.5 without any other comorbidities, diagnosed comorbidities, or a BMI of more than 32.5 with comorbidities, or documented failed attempts of non-surgical weight loss, no medical contraindications, and absence of uncontrolled psychiatric conditions. These are the absolute contraindications like severe alcohol or drug abuse, pregnancy, presence of infection, uncontrolled psychiatric disorder, particularly schizophrenia, because these patients don't understand the lifestyle modification, so it's no use performing the surgery, and mental retardation, that is IQ less than 50. So relative contraindications are like inflammatory bowel diseases, severe heart, lung, or liver diseases, which make anesthesia and surgery very, very complicated. History of autoimmune diseases such as scleroderma or systemic lupus, and chronic pancreatitis. So coming to risk of surgery, you have to explain the risk of surgery to the patient and take proper consent of the patient. These patients usually perceive that the surgery is not life-saving, and they perceive it as most of the patients perceive it as only cosmetic surgery. But we had a patient who had a BMI of 65. His pulmonary arterial pressure was somewhere around 80. He could not even walk for 10 feet without stopping. And when I asked what are your problems, so he was like, just thoda sa वजन जास्त है, बाकी काही problem नाही मला. So you have to make them understand that if you don't do this surgery and you don't lose your weight, you are at a very high risk of dying from sudden cardiac arrest and ischemic heart disease, or all the other problems. Emergency surgeries, if taken, the patients are even more at high risk because they are not optimized at that time. So if the BMI is more than 30, the patients come under ASA physical status 2. And if the BMI is more than 40, then they are grade 3. For all patients, better take a consent for photography, because if you want to, if you would like to publish these cases, then you should have this consent. This is the obesity surgery mortality risk score. Now, what are your anesthesia goals? So you should go ahead with a normotensive balanced anesthesia, and the patient should have no awareness. You should use opioid sparing multimodal analgesia. Your patient should be completely awake and coherent post-operatively. No residual neuromuscular blockade should be present, and patient should be absolutely pain-free, because you want to mobilize a patient within 2 hours of surgery. Before induction, you should consider a few points. These patients are most of the times dehydrated because firstly they are fasting. Secondly, they are on a restricted diet by the surgeon, which is a liver diet to shrink the size of the liver before surgery. So most of them are dehydrated. They are on multiple preoperative medications which have to be optimized and titrated. Patients are at high risk of gastric regurgitation because most of them have hiatus hernia. They may be difficult airway. But you have to remember that most of these patients are difficult to ventilation rather than difficult intubation. The ventilation is difficult because of their cheeks, because of their fat pad below their chin, big difficulty in holding the mask, and because their tongue size is huge as compared to their oral aperture. So they have most of them have large fleshy tongues, and you have to consider excellent pain management. So for pre-medication, you should establish a good IV line, at least a 20 gauge cannula, and you have to hydrate the patient with at least a 50 ml of balanced salt solution before induction. They have large volumes of distribution, and all our anesthetic agents are venodilators, or they dilate the capacitance vessels. So once you give propofol, these patients tend to have a precipitous hypotension. So you have to fill their capacitance vessels with fluid before you induce the patient. They should receive gastric acid prophylaxis. The patients during their prehabilitation phase only, they are just mostly started with nebulization. So you have to continue that perioperatively. Continue beta blockers, and if the patient is on angiotensin receptor blockers, then you switch that to amlodipine, because telmisartan and losartan, olmesartan, all these drugs may cause precipitous hypotension in these patients. The oral hypoglycemic agent should be stopped, and they have to be converted to short-acting insulin with blood sugar monitoring. And preoperative glucose loading like maltodextrins can be considered till about 2 hours before surgery. Pre-induction, you have to prepare your OR with equipments and personnel. Difficult airway card should always be kept ready. All emergency and anesthesia drugs should be ready beforehand. If possible, ask patient to shave his beard. And 2 good IV lines should be taken. Or 1 good IV line should be taken, and second IV line you can insert after you induce the patient. Monitoring, you have to pulse oximetry, non-invasive blood pressure and ECG monitoring are mandatory. End-tidal CO2 also is mandatory. For blood pressure monitoring, most of these patients have conical arms, so it is very difficult to fit in a BP cuff to their arms. Even if the patient's arm is not conical, they require a extra large size BP cuff. The bladder of the BP cuff should at least cover 2/3 of the circumference of the arm. Or if the blood pressure cuff is not fitting, you can fit a normal size BP cuff to the forearm of the patient, and you first take the pre-op BP reading and keep the intraoperative blood pressure readings in the same range. Then anesthesia gas monitoring is better done. Temperature should be monitored to prevent hypothermia, because many of the carbon dioxide insufflators don't give warm carbon dioxide. Then the patient tends to become hypothermic, as they have very large areas for losing temperature. Anesthesia depth monitoring is ideal. Neuromuscular blockade should be monitored, and airway pressures have to be monitored. Invasive monitoring is better avoided. It should be, invasive arterial pressure monitoring should be considered only in morbidly obese patients in whom BP cuff is not fitting. Severe OSA patients requiring recurrent arterial sampling. If the patient has severe pulmonary arterial hypertension, and if IHD with compromised LV function. Central venous cannulation can be considered only for IV access if the peripheral IV access is very difficult, because most of these patients have PH, so their CVPs are all they are not a good indicators of their volume status. So there is no use monitoring CVP as such. These are the basis how you can titrate various drugs. Propofol, thiopentone, they are usually the inducing doses are given according to lean body weight, and infusions if required are given according to the adjusted body weight. All opioids are started with lean body weight, and they can be titrated as and when required. Scoline is one drug which should be given according to total body weight, but still maximum 200 milligrams only can be given. The non-depolarizing muscle relaxants are usually given according to the ideal body weight, because they mainly act on the muscular compartment. Paracetamol is given according to lean body weight. Neostigmine is given according to adjusted body weight, but maximum dose of 5 mg is only given. Sugamadex is also given according to adjusted body weight. Low molecular heparins are given according to total body weight, but the dose is reduced, like from 1 mg per kg, it is reduced to 0.4 to 0.5 milligrams per kg. Antibiotics are usually given according to adjusted body weight, and dexmedetomidine and vasopressors are usually given according to lean body weight. So this is the ramp position, or so the patient is kept in propped up position with a roll below the shoulders. This can be achieved with pillows and sheets if you do not have a ready-made ramp. Ramp is rapid airway management position or a health position. That is a head elevated laryngoscopy position. Inflatable and silicone ramps are also available. From the photo, you can see that without using the ramp, it is very difficult to ventilate the patient. But when you, for the same patient, if you put in a ramp, his neck opens up, and the ventilation and even intubation becomes very easy. In the third picture, I have shown how you can prepare a ramp using only sheets and pillows. So what all you need to keep ready for ventilation? You should have large size face mask with a good fit. The head tilt and chin lift and jaw thrust position should be maintained. Two-hand mask holding technique is better than one-hand mask holding technique. Always keep a LMA or IGEL ready at hand if ventilation is not possible. And beware of patients with beards and chubby cheeks. These are difficult airway predictors. If the patient has large fat pad below the chin and behind the neck, it is difficult to position the patient for ventilation. If the patient has beard, the mask fit is not proper. Limited neck extensions, especially in patients who have long-standing diabetes, mandibular problems like retrognathia, macro or micrognathia, prognathia, missing or loose teeth, or if neck circumference is more than 40 centimeters. So how do I go about inducing the patient? So pre-operatively, 15 minutes before induction, I prefer to give paracetamol 1 gram with Maxel 2 grams and lignocaine 100 milligrams. Pre-oxygenate the patient. These patients usually have a very reduced safe apnea time. Mostly it is on an average, it is 2 to 2.5 minutes. Whereas in adult athletic male, it may extend up to 9 to 10 minutes also. So you have to oxygenate the patient to increase the safe apnea time. I usually prefer to induce the patient using fentanyl, ketamine, and propofol. Ketamine helps in sparing the need of fentanyl or opioids. Also, it prevents the precipitous hypotension which may accompany propofol induction. So, ketamine is a very useful co-induction agent in most of the obese patients. The ideal muscle relaxant is cisatracurium or rocuronium because they do not have any cardiovascular side effects. And rocuronium can be easily reversed nowadays with sugammadex. So even if in a difficult airway situation, you can go ahead with using rocuronium. Atracurium may cause severe hypotension in this patient with vasodilatation and histamine release. Succinylcholine can be used in anticipated difficult airway situations. These patients have, as I said, reduced safe apnea time. So apneic oxygenation using nasal prongs or Thrive can be used. Succinylcholine and fasciculations associated with it may increase oxygen consumption further and may further reduce the safe apnea time. So succinylcholine is a double-edged sword. Tube size usually is chosen according to the ideal body weight, but in very large BMI patients, the tracheal diameter may be slightly reduced. So one size smaller tube may be required. Ventilation is always controlled. The bariatric surgery is usually done laparoscopically. So a patient should be intubated and with controlled ventilation. We use a low tidal volume and higher rate ventilation. The tidal volume is ideally between 6 to 8 ml per kg. A PEEP of 5 to 7 centimeters of water is mandatory. And peak airway pressure should be maintained below 35 centimeters of water. The IE ratio is kept around 1:2. And head up position is maintained throughout the surgery. Maintenance is usually, I prefer air, oxygen, and inhalational agent with low lipid solubility like sevoflurane or desflurane. Nitrous oxide is ideally avoided to prevent hypoxia, and in patients with pulmonary hypertension, we don't use nitrous oxide. Dexmedetomidine infusion can be used at a dose of 0.0 to 2.08 milligram per kg body weight. I prefer giving infusions rather than a bolus dose. But because bolus dose may cause higher frequency of hypotension and bradycardias. So an infusion started just immediately after induction is better. Rocuronium or cisatracurium is preferred, and neuromuscular blockade should always be reversed at the end of surgery. Never leave the patient without reversal. The inhalational agent of choice is obviously desflurane is the most preferred as the metabolism in body is very less and its oil gas partition coefficient and blood gas partition coefficient is even better than sevoflurane. Now coming to recruitment. So what is recruitment? To keep the alveoli open. So you prevent the collapse of alveoli after expiration. It is easier to inflate a already half open alveolus like a balloon. It is easier to inflate a half filled balloon rather than a deflated balloon. So similarly, if recruitment is done, how do you do it? You start CPAP preoperatively. While mask ventilation, you start PEEP. After intubating the patient, you give 5 to 6 vital capacity breaths using high PEEP of around 40 centimeters of water. Ideally, at least 3 times immediately after intubation, after pneumoperitoneum, and before extubation. If your patient, if on ventilator, if you want to give recruitment maneuvers, then you give 4 breaths each at PEEP of 12 or 15, then 12, then 10, then 7, and then keep a continuous PEEP of 5 to 7 centimeters of water throughout surgery. So this is the position used for bariatric surgeries. The patient is usually in a steep head-up position. So before starting, you tie the patient to the OT table and you check the position and see whether your patient is not slipping or the belts are not loose to avoid any accidents during surgery. Most of these patients have arthritis, they have spine problems, they may develop compression fractures, so they require adequate care. Also, they are at a high risk of neural and bone injuries, bony prominences injuries and ulcers. So they require adequate padding. For analgesia, I use a multimodal analgesia. So pre-operatively, we use paracetamol, Maxelf and lignocaine. NSAIDs like diclofenac or ibuprofen can be given after induction. Dexmedetomidine infusion can be started. I extensively use regional anesthesia for these patients. Either a tap block or four-quadrant tap block or erector spinae block can be given after induction. Local anesthesia infiltration can be given before incision by the surgeon, and before closure, intraperitoneal subdiaphragmatic local anesthesia installation can be done by the surgeon. So this is how a tap block can be given. You can see the needle entry between the and the tip between the internal oblique and the transverse abdominis muscle. In obese patients, without assistance, giving this block becomes little challenging. So you can ask an assistant to pull the pad of fat away from you so that you can visualize the muscles in a better way. Because as I said previously, sometimes the abdominal wall thickness is itself 6 to 8 inches. So it becomes difficult to visualize the muscles under UAG. So this is a video of the subcostal tap block. So the needle, so I'm injecting the drug between the rectus abdominis and the transverse abdominis. You can see the needle coming from, now you can see the needle. So first you give a small dose and see whether you are in the correct plane, and then you can reposition the needle and deposit the drug between the rectus and transversus. So this is the video of erector spinae block. So these are the finger-like processes are the transverse processes, and the erector spinae muscle is above the transverse processes. Here you can't see the needle properly, but you can see the spread of the local anesthetic just below the erector spinae muscle and above the transverse processes. For this block, you use a curvilinear probe, but for a tap block, you use a linear probe. These patients are very high risk for DVT. They may be dehydrated. Obesity itself is a pro-coagulant and pro-inflammatory disease. Patient has decreased mobility pre-operatively. As you say, as they say, the patients are obese because nobody runs in the family. So they have very decreased mobility pre-operatively. Also, position during surgery is a steep head up, which again predisposes to deep venous thrombosis. So we go ahead with the multimodal approach again. So we give the patient good hydration perioperatively. We use TED stockings. We use a sequential compression device pre, intra, and post-operatively. Patient is mobilized early within 2 hours of surgery, and pharmacological prophylaxis with low molecular weight heparins. Ideally, first dose is given 12 hours prior to surgery. Second dose is given 12 hours after the surgery, and then once a day dose till the patient is discharged. Usually these patients are discharged on second post-op day. Fluid management, usually there are no contraindications for fluids. I usually give up to 10 ml per kg of lean body weight of balanced crystalloid solution. And we encourage the patient to start sips of water orally post-operatively within 4 hours. Extubation, the patient should be reversed before you awaken the patient, because all these inhalational anesthetics, sevoflurane or desflurane, the patient becomes awake very fast. So if you don't reverse the patient before you awaken the patient, the patient usually wakes up very angry and throwing everything and in a distressed state. So first you see that patient comes out of the neuromuscular blockade, you reverse the patient, and then you awaken the patient. The patient should be in a propped up position while extubating. Patient should be wide awake. The airway reflexes have to come to normal, and patient should be generating good tidal volumes before you extubate the patient. Keep difficult airway cart ready even during extubation, always. And you insert a adequate size nasopharyngeal airway before the patient becomes awake. Post-operative care is usually given in a propped up position of 45 degrees. Oxygen therapy should be given only if needed till the patient is mobilized. you should not target the saturation at 100%. You should target it as at pre-op levels. If the patient's pre-op oxygen saturation is 90% on room air, then target it at 90% only. Don't try to make give more oxygen and make that saturation to 100%, because these patients have lost the hypercapnic drive to their respiration. They only have hypoxic drive. So if you remove that hypoxia, the patient stops breathing and he may go into respiratory failure. So maintain oxygen saturation at his pre-op levels at whatever level the patient is acclimatized to. Normal saline nebulizations and bronchodilator nebulizations can be given if as and when needed. Sequential compression devices should be continued post-operatively. IV fluids post-operatively should be given 100 to 150 ml per hour, a balanced fluid solution or a dextrose containing solution alternatively. Usually in diabetic patients also, their blood sugar normalizes very fast after that is one of the first thing to normalize. So you should keep a watch on their post-operative blood sugar levels. Within 3 to 4 hours, the blood sugar levels start coming back to normal. So you have to monitor their sugar levels and give dextrose if needed, and mobilize the patient within 2 hours. You have to give analgesics should be continued round the clock, like NSAIDs. No opioids and no sedatives to be given. Tramadol absolutely avoided. Firstly, it causes a lot of nausea, and also it causes a lot of sedation. So tramadol is mostly avoided. Sips of water after 4 hours. Ondansetron and proton pump inhibitors should be continued round the clock. As I stressed upon BSL monitoring round the clock. Encourage the patient to walk every hour. And don't restrict the patient with urinary catheters, infusions, or other invasive lines or any other devices, because the more you restrict the patient, the less will be the mobility and the more you will predispose the patient to development of DVT. If complications occur, they are very difficult to assess. You cannot, on palpation, you cannot assess anything. Most of the times post-operatively, after pneumoperitoneum, USG also becomes very difficult. We had a patient who was bleeding in the stomach, and patient could not fit into the CT scan. So a CT scan also becomes difficult. Though many times persistent tachycardia is the only sign that the patient is having some problem, or excessive pain. If the patient complains of excessive pain in spite of your regional anesthesia, in spite of your round the clock NSAIDs going, then you should search for complications. And the most dreaded problem is rhabdomyolysis. So you should avoid hypotension, immobility, dehydration. And if the surgery is prolonged, you should give good fluid resuscitation, diuretics, and urinary alkalinization. And that's all from my side. Thank you very much for giving me this opportunity. Thank you, ma'am. Thank you, sir.
It was a very good presentation, Dr. Rashmi.
Yes, it was a very good and very informative. So to start the discussion, I would like to ask Dr. Rashmi madam. Madam, this obese patient has a extra volume, but not up to the mark as per their weight. So if they are extra starved, so they tend to get hypotension immediately after induction. So what do you do if the patient is starving more than 6 hours?
We have to
So how much fluid do you replace before induction or during the induction?
So like I said, take 2 IV lines, 1 IV line before induction. I give at least 500 ml of Ringer's lactate or plasmarate cabilate or a balanced crystalloid solution basically before inducing this patient. I like to induce with ketamine co-induction to prevent this rapid hypotension or due to propofol. So ketamine is a very good agent to be used. And secondly, intraoperatively, you can give as good as 10 ml per kg of lean body weight of balanced salt solutions to these patients.
Yes. Do you prefer giving a carbohydrate drink before 2 hours before the surgery?
Yeah, then that is what I said. According to ERAS protocols, we can give maltodextrin 2 hours before the surgery. But again, for these patients, many patients have hiatus hernia. So they are higher risk for regurgitation and aspiration. So you have to weigh the risk benefit ratio and then whether to give maltodextrin, the oral fluids or not 2 hours before is a little dicey thing in these patients.
Yeah, because nowadays they are saying giving a oral solution, dextrose solution, they decreases the insulin resistance in the
Yeah.
post-op.
Yes.
Post-op period, and the sugar level can be very well managed, and plus the starvation period is also decreased, so the immediate induction, after immediate induction, there is less chances of going into the hypertension also.
So you can give maltodextrins, and before induction, you can just do a quick USG gastric.
Yes, focus
volume
is a very good tool
focus
to assess the
and accordingly.
and during the sleeve gastrectomy, do you prefer putting a gastric tube or normal Ryle's tube?
No,
What
no.
is your protocol?
The surgeon usually insists on putting a gastric tube because they resect the stomach, maintaining that gastric tube as a guide. So you have to introduce the gastric tube, and first you introduce the gastric tube as much it goes, and then when the surgeon puts in the laparoscope, then under vision you introduce the gastric tube further, with laparoscopy guidance, because the stomach usually these patients have huge stomachs, and the stomachs
Yes.
may be coiled on themselves, so you don't know where that gastric tube is going.
Yes.
So it is always preferable to insert it after the patient puts in the laparoscope. You insert it in the stomach and just stop.
Okay.
Then under vision, you further go ahead.
Okay.
Okay.
Uh, can you yes, Sangeeta madam.
Dr. Rashmi, you are doing so many bariatric cases. So have you any time faced difficult airway, and you have used fiber optic intubation for such cases?
So fiber optic intubation is not needed. I have
Not
never used
needed.
fiber optic. I have had difficult intubation cases with patients with prolonged diabetes who have neck mobility issues. But if you give a RAM position and you have a McCoy blade, you can intubate these patients. These patients usually are not for difficult intubations. They are difficult to ventilation.
Ventilation, yes, yes.
Yes.
Do
So
you
if
use
you have-
video
So-
laryngoscope, madam?
Yeah, video laryngoscope also we can use. But they don't
Yeah.
require video laryngoscope also. They
Okay.
are not usually difficult intubation patients.
Most of the time, Malampatti grade 2 or
Yeah.
1 only. Only thing the mask ventilation is difficult
Large
because of
ventilation.
fat deposition.
So you
Yes.
can use a LMA or a nasopharyngeal. Nasopharyngeal airway is very good actually for these patients. Immediately
Yes,
after
yes.
induction only, if you put in a nasopharyngeal airway, you can have good ventilation before intubation also and after extubation also.
Mangal, what is your
And
experience
with
about?
What,
with
ma'am?
that, you can also increase the safe apnea time also. So you can give oxygen through the nasopharyngeal airway till you intubate the patient. So the safe apnea time can be increased with that
Or even a
maneuver.
simple nasal prongs will do that.
Nasal prongs. Yes, yes.
May I ask, madam?
Yes, yes, Sujata. Yes.
Madam, I just wanted to know, with your vast experience, did you come across any patient who was good in the ventilation, and after giving sedation, patient had an airway collapse and he was not able to ventilate? Any such episode or accidental issue?
Ventilation is always difficult, many times. So first you have to assess whether you can ventilate the patient, then you can give a neuromuscular blocking agent. And also the contraindication is after you give a neuromuscular blocking agent, the ventilation becomes easier.
Okay.
So again, you have to weigh the whether you can ventilate, see whether you can ventilate the patient. You always keep a LMA ready because LMAs fit in nicely. In
Yes.
this.
And as Supriya madam said about apneic ventilation, high flow nasal oxygenation devices, HFNO is also very much useful, and so that you can buy time for and can give an apneic oxygenation in that case.
Madam, I have two questions. You mentioned something about the pre-operative ABG. So what are your criteria where you can say that these patients are not fit currently for the surgeries and required some pre-op optimization? And the second question is, what are the post-operative analgesia you usually use? Because you mentioned you are not using any opioids.
Yeah, according to when the patient comes for advanced PSC, first I stop bank scoring. Then I assess his level of consciousness. As I mentioned previously, we had one patient who was dozing off while speaking to me. Now, obviously, such a patient you cannot take for surgery because then he is a high risk candidate for going into respiratory failure post-op. Secondly, his ABG is to be done more for quantifying his preoperative CO2, PCO2 levels. So that post-operatively, if the patient goes on a ventilator, you don't have to come back to normal PCO2 levels to extubate the patient. You have to accept some amount of hypercapnia because that patient is acclimatized to that level of hypercapnia. And the third criteria is pulmonary arterial hypertension. That is a very common thing seen in obese patients. And the treatment for PH in obese is oxygen and CPAP. With 15 days of CPAP, the pH levels come down from severe to at least moderate. Means I have seen one patient we optimized after admitting him to the hospital. His pH was the patient with 65 BMI, whom I mentioned. His pH was 84 pulmonary arterial pressures. And by CPAP and oxygen therapy, within 15 days, that pulmonary pressures came down from 84 to 40, 45. He was a 30-year-old male, otherwise only hypothyroid, hypertensive, and PH. But I had to really coax him to use CPAP. He was like, I don't want to use this. I don't like this. Why should I use this? I only have a small problem. My weight is only little bit more. And if you see the patient, he is very bad.
Denial is there generally.
Yeah.
Yes.
And second part is analgesia, post-operative analgesia.
Post-operatively, round the clock, you have to continue analgesics with paracetamol, diclofenac. Diclofenac, you can give BD, paracetamol, you can give QID also, 1 gram per kg lean, according to lean body weight. And if you give tap block or erector spinae block, usually the patient has no pain for first 20 to 24 hours. In my, the drugs I used for blocks is usually 0.25% levo and bupivacaine, and I add dexamethasone to it. So dexamethasone increases the duration of the block up to almost 24 hours. And the best part of laparoscopy is severe pain is there only for first 24 hours. After 24 hours, the pain is usually tolerable and it can be managed by NSAIDs. So regional anesthesia is a very basic part of bariatric anesthesia. If blocks are not possible, you don't have UHG at your center, you can tell the surgeon at least to infiltrate the incision sites before inserting the ports itself. And so lastly, to instill lot of local anesthetic in the peritoneal cavity subdiaphragmatic before she comes out or he comes out.
May I ask one question?
Yes, sure.
What is the incidence of, you said incidence of pulmonary hypertension is quite high in these patients.
Yeah.
So how you modify your technique of anesthesia and post-operative, what care you will advise for that?
The treatment first we optimize, or we don't accept patients for anesthesia if the patient has high, moderate to severe pulmonary hypertension. So we optimize the patient. We bring the pulmonary arterial pressures to mild to moderate first. We can optimize the patient for even 1 month, 2 months, 3 months, and then we take the patient for surgery. These patients don't go anywhere, and if they go to some other surgeon, then that is disastrous. If you operate them without optimizing.
Because mortality is very high, pulmonary
Very high
hypertension is
pulmonary
there.
hypertension.
And what
So,
special precaution is needed in post-operative period in such cases?
usually they don't require anything special because you have optimized the patient.
Yes.
And
So
if you
what
have not optimized, then oxygen therapy, because oxygen is the best pulmonary diuretic in obese patients. So oxygen therapy, CPAP.
And invasive arterial monitoring, these patients of pulmonary hypertension, do they
They
require?
have moderate to severe pulmonary hypertension previously. Then we would like to put in an arterial line because we would be sampling sending ABGs quite frequently. So we would like to put in an arterial line, which we can remove post-operatively if not needed after 4-5 hours.
There is a obesity surgery mortality score also, risk score.
Yeah, I had shown in the
Yes.
that in one of my slides.
Yeah. So I have a question to Dr. Mangalmurthy.
Yeah.
What inference is you feel important to take from the sleep study before going to proceed for the anesthesia? So usually these patients must have undergone the sleep study overnight, and they found some AHI index. And what do you feel which is important and can alter our anesthesia management?
Yeah. Can I share the slide?
Yes, yes.
Yeah. Just a minute. This is the last page of sleep study. Just a minute. This is the last page of sleep study where what is important is apnea hypoapnea index AHI and minimum SpO2. So in
Yes.
routine patient, if AHI is more than 30, we should not accept this patient without optimization. Optimize for 15 days. And these patients are used for low saturation. So we need not to fear for its fall in saturation because they are
Yes.
their body is used to that. Even we do drug-induced sleep study without oxygen. So
Yes.
important is AHI, main important, more than
Okay.
30.
Okay.
Adult patients.
And these patients are usually adjusted with the high EtCO2 level.
Yes, yes.
In fact, it is a trigger for breath from the
Respiration.
apnea.
Yeah.
Yeah. So during intra-op, what do you keep? What do you prefer? EtCO2 level. Which level you keep that?
Intraoperative, I keep normal EtCO2 30-35 because higher EtCO2 will rises their BP and which causes, just a minute, I will show it. Higher EtCO2 will causes rise in BP and there is excessive bleeding. That's why I usually maintain EtCO2 between 30 to 35. And parameter management is very important. Heart rate, BP, normothermia, and EtCO2. Because if we maintain good depth of anesthesia, post-op pain will be less, post-op discomfort will be less. So maintain normal parameter. They are used for high EtCO2, but maintain normal. That is the crux.
Okay.
Mangal, Dr. Mangal.
Yeah.
Yeah, you said that these patients are used for low saturation, right? So the autoregulation curve is fixed. So if you do a pre-op ABG in this patient, do you find any difference in PO2?
ABG, when we कोणत्या वेळेला आपण ABG करतो, that is very important. If patient is wide awake, then ABG will be normal. And patient's scoring means whether he is having mild OSA, moderate OSA, severe OSA. In severe OSA and patient is sleeping and then you are doing ABG, then you will find hypoxia, hypercarbia, metabolic respiratory acidosis, all picture of that respiratory acidosis because of hypercapnia. But when patient is conscious, ABG will be normal. So
in the
ABG will not.
in the post-operative period, if the patient gets complicated because of hypercapnic and all those things, so what ABG will be significant? Means, do we really need to act on the ABG parameters?
Actually, in post-op, what is basic is monitor pulse rate, respiratory rate, saturation, check for good tidal volume breathing, adequate tidal volume respiration, and check for whether there is a airway obstruction. I usually put up just after extubation, I put anesthesia mask over the patient's face, tight anesthesia mask, and check for whether the our bag is moving or not. कि bag is not moving, that means there is a airway obstruction. Means patient is taking breathing, but bag is not moving. That means there is a tongue fall and obstruction. So we need to put oral or nasal airway as per scenario. And once we put oral airway, then keep it there till patient become conscious. Usually there will not be any complication. Important, just a minute. Important is extubate patient only when we are confident that all anesthesia drugs are metabolized. So usually many a time we need to wait for 10 to 15 minutes or 20 minutes for extubation after giving reversal, maybe.
Okay, thank you.
In obese patients who are chronic obstructive sleep apnea, their CO2 is many times on a higher level and their PO2s are many times on a lower level. And they are acclimatized to that levels of PO2 and PCO2. So intraoperatively, if you have a baseline ABG, then try to maintain the PCO2 levels at the same level at what they are used to. So that prevents, because they are already in a compensated respiratory acidosis types. The pH may be normal, but the CO2 is higher. PCO2 is higher. So try to maintain the PCO2 at the similar levels so that there is not much of a shift in the acidosis pH of the patient. Also, I would like to share the this thing, risk, obesity, this thing, risk stratification.
Yes, yes.
Yeah. Meanwhile, I just want to know, madam, have you come across any cardiomyopathy post-operative patient as a complication of cardiomyopathy because of all this pulmonary hypertension and
Post-operative obese patients
very
many
operative
times might
rather.
have cardiomyopathy because of fat deposition in their myocardium and in their conduction pathways also. So they are more sensitive
Yes,
to
they are more
arrhythmias because of
arrhythmias also.
sometimes higher PCO2 levels may induce arrhythmias. Sometimes stress may itself induce perioperative stress may itself induce arrhythmias, or pain may induce arrhythmias. So they are at a high risk of obesity-induced cardiomyopathy. Also, the other thing is NASH, or that is non-alcoholic steatotic hepatitis or cirrhosis.
Hepatitis.
And these patients usually the blood flow of fat, the fat component receives quite a high blood flow, almost 2 ml per 100 milligrams of fat per minute. But in spite of this high amount of blood flow, the core part of the fat, if there's a fat globule, the outer layer receives good blood flow, but the inner layer is always ischemic or hypoxic, or less, it receives less amount of blood flow. So there is a chronic inflammatory condition pre-existing continuously in their bodies. So there are problems with wound healing, their CRP is raised, and they have a lot of other they are estrogenic, and they have a lot of these inflammatory conditions predisposing them to DVT and pulmonary embolism.
Okay, thank you so much. And in what is the biggest figure on weight you have given anesthesia till the date? Just out of curiosity.
70 kgs. 272.
Sorry?
272 kgs.
272.
Oh my God.
Oh my God, unbelievable.
Madam, have you come across any time with rhabdomyolysis, post-op rhabdomyolysis?
Thankfully, no, not.
No. Yes.
Madam, I would like to just add one thing. We use generally a foam grade mattress to prevent that sliding of the patient. Generally, we are giving a stiff head low position to our robotic patient, and that mattress is really helpful.
Anti-skid mattress.
Anti-skid mattress, yeah.
Yes, yes.
Yeah, but still, in bariatric surgeries, the patient has a steep head up position.
Yeah.
Anti-skid mattress only is not useful. You have to tie the patient to the
restraining. You have to restrain it for a certain speed. Yeah,
you have to tie the patient to the table,
yes.
because the patient may just slide off. And if the patient slides and falls, then that is a catastrophe.
Oh, that is a catastrophe. Exactly.
Ma'am, there is few questions in the chat box. Even I was supposed to ask the same thing, how you find the good peripheral line during the long-term care.
Usually dorsum veins are good, and I have used in 2 patients sonography guided peripheral IV line access also. Because one of the patients was very dark complexion, had a very dark complexion. So no veins were visible post op. There were 1 or 2 veins which we use intraoperatively, and then post-operatively I couldn't see anything. So then I have used UHG also for peripheral venous access, not for IJ central. For peripheral also you might need UHG guidance.
Ultrasound.
Yes.
Yes.
And
Being,
Can I
usually
add
which
one
gauge,
point to this
which
peripheral
gauge
IV?
do you take, 20 or 18, 16?
If you use UHG, then you have to take 18 gauge only, because the depth and all are not with 20 gauge. The depth you cannot reach the vein only with 20 gauge cannula many times. But minimum 20 gauge you have to use, not
Yes.
20.
How long does the procedure last in general?
A sleeve gastrectomy usually lasts for 1.5 hour, and usually 1 hour. 40, a good surgeon takes 40, anything between 45 to 1 hour, and even a gastric bypass takes maximum 2 hours through
Okay.
and by.
Do you adopt a rapid sequence in intubation routinely, madam, for these patients? One of the question in chat box.
Cricoid pressure I don't like. Rest all we give a head up position. That is usually sufficient. Head up position itself prevents regurgitation, and I don't use choline.
Okay.
There is one more question from Dr. Nikhil Mudgalkar. Can I
So
answer?
madam already explained it about the arterial line and invasive lines.
Yes.
No, it is regarding.
So one question was there.
Question, I think.
Whether do you prefer?
Pardon
Yeah.
me? I didn't get it.
One question was there. Whether do you prefer TIVA over the inhalation?
I prefer inhalation, because desflurane, the recovery with desflurane is very smooth and very fast.
And then what about green, this thing, carbon footprints, desflurans?
We should stop driving cars first. We
Yes,
should also start cycling.
we use for safe anesthesia.
What a quick response from madam. We should start cycling.
War is giving
Keep us all
going
fit
on
also.
every part of the country.
Sachin is working on marathon. So we should also do the marathons from one center to the other center. And then we can
Yeah.
safely use desflurans. Perfect.
Anyway, so I think most of the questions are answered. Now, coming to the last part of the session, that is the vote of thanks, and I would like to request Dr. Reshma Bhosle for giving vote of thanks.
Thank you,
One
sir.
last,
Okay.
one last question was that the Ramifentanil, but I think Ramifentanil in our city is not available. So probably the metropolitans can take the advantage of Ramifentanil.
Remifentanil is a good agent. We can use
Yeah.
remifentanil, but many centers remifentanil is not available.
Available, right?
And again, the cost of remifentanil restricts its usage.
Mhm.
Because if we use low flows, like I use usually 0.8 to 1 liter flows. So with that flows, the desflurane consumption is very less. If you have a good anesthesia workstation, if you
Yes.
use pressure control mode and low flows, the desflurane usage is very less.
Yeah.
In 1 hour, you might end up using 20 to 25 ml of desflurane.
And
Maximum.
you give fentanyl at 1 microgram per kg only. So that it's sufficient for 1.5 surgery.
Reshma, you can continue.
Yes, Reshma, please continue.
Okay. Thank you, sir and madam. Again, very good evening to everyone, respected chairperson, esteemed speakers, guests, and dear colleagues. On behalf of organizing team, it's my great privilege to propose the vote of thanks for this highly informative and enriching webinar on the important topics of anesthesia for bariatric surgery and anesthesia for OSA surgery. First and foremost, I would like to express our sincere gratitude to our esteemed speakers, Dr. Mangal sir and Dr. Rashmi madam, for sharing their valuable knowledge, clinical expertise, and practical insights. I extend my gratitude towards SAM's office for providing such a wonderful platform to conduct various academic activities. Heartfelt thanks to our respected chairperson for guiding this session and for ensuring meaningful academic discussion. Thanks to all the participants who joined us today. My sincere thanks to all the office bearers of our team, AAA, President Dr. Sangeeta Madam, our Secretary, and all the office bearers. Thank you all once again for your valuable time, contribution to advancing knowledge and improving patient care in anesthesia practice. Thank you.
Thanks everyone, Rashmi madam. And
Thank you,
Thank you,
Rashmi madam.
Rashmi
Thank you,
madam.
Dr.
And
Mangal.
thank you,
It was
Mangal.
very
Thank you, madam.
Mangal also.
Thank
Thank
you.
you, everyone.
Thank you very much for
Thank you, Dr. Rashmi, Dr. Mangal.
wonderful interacting with us.
See you again.
Yeah, yeah.
Yeah.
Same.
Yes, see you again, ma'am.
Yes,
With
Yes,
different
sure.
topics.
Yes.
yes, yes.
Sure.
Thank you.
Thank you.
Congratulations, Sangeeta Madam, Sachin, and all
Yes.
AA members
Thank you,
for
madam,
organizing
for
such
sharing
a
this
nice
session.
webinar. It's
It's a
really
team
academic
effort.
feast.
Yeah.
Thank you so much.
Thank you
Good night.
and good night.
Okay, yeah, good night.
Night.